Thank you very much, and thank you, Dr. Wakar, for inviting me to speak today. Now, the challenge that I've been given is to speak about vasculitis in 20 minutes, which I think is impossible. So this is why I'm just going to touch base, run through, and hopefully give you a message that can help, because when we talk about vasculitis, it's a huge, vast field, and then obviously we come across in our acute setting as well as they have long-term consequences, multiple things can happen. So we have to see what we can do when you see the patients in your acute setting. So briefly, we're going to talk about what is vasculitis, when should our diagnosis be expected, how do you make it. There are certainly mimics of vasculitis, which is a challenge for us all the time, because once we are asked to see a patient suspected of vasculitis, we have to make sure that the acute medicine is happy, the infectious disease is happy, the other pathologies, especially the oncologists, are happy before we can manage and start our treatment. And then the initial treatment and staging. And obviously, once they have this diagnosis, it's not something that they'll get away with. They start seeing us, and we have to follow them up for long term, for quite many years. So what is vasculitis? As I have said earlier, it's not a single entity. It's a heterogeneous group of pathologies characterized by inflammation of blood vessels. And usually the clinical and the pathological features are based upon the vessels involved, the sizes of the vessel involved, the type of the vessel involved, and the site. So you can imagine it can happen anywhere, and then obviously it's a challenge for all, starting from the primary care to the end. It can happen as a primary process, or could be part of another underlying condition. And usually we never find the reason, and that's the truth with most of the other autoimmune conditions. You never find the reason, but at least you have to treat them. They say there are more than 30 kinds of vasculitis, which I agree in a way. Previously, before the CHCC, the American College of Rheumatology came up with a classification, and they gave us about 7 forms of vasculitis, which I'm sure most of us are aware of, including polyarteritis nodosa, Church-Strauss, Wegener's. By the way, all these names have been changed. Hypersensitivity vasculitis, Hemlock-Schönlein-Purpura, giant cell temporal arteritis, the classic example, and then you have Takayasu. Later on, the International Chapel Hill Consensus met in the early 1990s. They came up with the nomenclature for vasculitis, but again, it was very ambiguous. They sat again and then gave us what we know now. So in most clinical practices, this is what we use. So large vessel vasculitis, medium and small vessel vasculitis. And then I'm sure most of us, you already know what kind of large vessel vasculitis we deal with. The classic example is temporal arteritis, which we don't see here that much unless the patient is of Caucasian origin. So we see more Takayasu, but working in Dubai, obviously, it's a mixture of people from all over the world. So I have quite a few cases of both that we have to treat and manage. And then medium vessel vasculitis. I must say it's much more rarer now. Obviously, I don't see kids that much, so Kawasaki disease I've yet to diagnose and treat. And we have a couple. I was surprised that we have a couple of polyarteritis nodosa still in our database. And then the common one that I'm sure most of the hospitalists would come across is usually when they see the rash, unwell patient, small vessel vasculitis. And then the big group in that will be the immune-mediated one and the post-immune. So post-immune is the classic ANCA vasculitis. I'm sure by the time we suspect vasculitis, regardless of whether we need the testing for ANCA or no, that's done. So ANCA vasculitis, Wegener's, microscopic cholangitis, Church-Strauss, and how you would differentiate with them. I mean, obviously, biopsy is the gold standard, but sometimes we are not that lucky. So we have to look at the clinical pictures, the presentation, and obviously the eosinophils plus other comorbidity that come with it. And with the immune complex mediated, as the other colleague just spoke about, lupus. Lupus can do anything to our body, including vasculitis, IgA nephropathy. Classic example is the Hemlock-Schönlein-Purpura, cryoglobulitic vasculitis, which again I would say, since the treatment for the hepatitis C is much, much better, we rarely see this now, and other conditions, including Behçet's and Goodpasture syndrome. So when should we suspect a diagnosis of vasculitis? Obviously, it's a clinically heterogeneous group of diseases, so it's not possible to outline a single algorithm for them. So we have to really suspect vasculitis whenever there's a patient who comes in with a medical history, suspected of vasculitis. We have to examine it, and then aided by the laboratory and radiological findings. So what are the suspicious findings that can give us a clue that the patient might have vasculitis? I think most of us already know fevers, unexplained weight loss. In the ENT, typically they will have nasal crusting, upper respiratory tract infections, epistaxis. We have a few who came in with ocular inflammation, nothing else. They just had red eyes, red painful eyes, and then acute foot drop or wrist drop, telling us that a nerve is involved. Limb claudication, which usually is the sequelae of vasculitis most of the time. Unexplained hemoptysis, again in young, otherwise well patients. Hematuria, history of hepatitis, both B and C, and obviously rash, different kinds of them. So this is a busy slide, but I thought this would be a good one to show because it can tell us a lot about the different types of vasculitis, what sort of symptoms we should expect, and then the different diagnoses. Again, based on the large vessel, medium vessel vasculitis, and small vessel vasculitis, we can see that with large vessel vasculitis, typical example, as I've said earlier, GC and Takayasu, they can have limb claudications, absence of pulses. You can hear an arterial bruit if you're lucky, aortic dilatation, especially if they've had this for a long time without being properly diagnosed, and asymmetrical blood pressure. So bedside examination is quite useful. So whenever we have an intern, I always make sure they check the pulses for us because it can definitely give you a clue, especially if the patient has suspected Takayasu. And then with the medium vasculitis, you can see nodules, ulcer, livido rectularis, livido racemosa as well, which I have not mentioned here, involving the nerve. Multiple nerves can be involved, mononeuritis multiplex, and obviously as a sequel, you can see them as a gangrene of digits, which unfortunately is something which we do see, especially in patients who have advanced diabetes, other cardiovascular comorbidities, and if they get vasculitis with it, it becomes difficult to manage because you treat one thing and it can worsen the other. Obviously, it can present itself as microaneurysm. And we spoke about the medium vasculitis already. You can have polyarteritis nodosa, cutaneous, and the systemic form, and Kawasaki disease. Coming to, I think, the one that most of us commonly come across is the small vessel vasculitis. You can have purpura or ecchymosis. They can be vesicles, which you can feel with a bit of fluid in it. Hematuria, hemoptysis, splinter hemorrhages. You can have ocular symptoms, including scleritis, episcleritis, uveitis. So, and then here you can see the other groups in much more detail. I'm not going to go through them. So, yeah, one thing I must say, obviously, eosinophils. So, a lot of the time in vasculitis, they are raised. So, it can give us a clue if the eosinophils are raised. They don't have any other suspected signs of allergy. They are unwell. You should think of vasculitis. Obviously, I'm thinking. Okay. And what are the suspicious findings on physical examination? As we spoke earlier, obviously, sensory or motor neuropathy. They'll have purpura, they'll have rashes, sinusitis in the NT, nasal septal perforation, absent pulses, bruit. They can have blood pressure discrepancy. So when a patient with vasculitis comes in, you have to obviously examine them from head to toe, assess them all the systems, including the nervous systems and so on and so forth. So this just, again, it's a pictorial display of what we discussed. And it's a challenge, as I've said. Sometimes they might just have one spot. You think it's vasculitis, no other systemic symptom. So what do you do for them? So just obviously biopsy helps. But if they have multi-organ involvement, you cannot wait for the biopsy. You really have to get the treatment started. And this is where the challenge is, because there's an unwell adult. The ICU is looking after them. The cardiologists are involved. The pathologists are involved, your infectious disease is involved. So it's a decision they want you to make, whether they should get the therapy which can potentially make things better, give them life, or make it worse. So it's a challenge in that case, especially in an unwell adult, where you don't have any more information, you have to make a diagnosis. Classically, they will have, the systemic symptoms as we spoke about, flu-like symptoms, polymyalgia, polyarthralgia, headache, neck ache, weight loss, anorexia, fatigue, malaise. But the problem is this can happen in any unwell adult because of infection, because of other malignancies, or other systemic disorders. So I'm just going to briefly talk about this patient that we had very recently. She was a local lady, 55 years old, female, admitted through the AR with nausea and abdominal pain, poor intake. She was unwell, weight loss, all the classic symptoms that we spoke about, generalized weakness. And this was going on for about 2 months. And then she was admitted, and she had the CT-NG of the whole aorta. And you can see it looks like she had this advanced Takayasu for quite a while now and was not picked up. I don't know where she was treated before, but we did start her the treatment. The vascular surgeon was also involved as well, but according to him, he can do very little because all these changes that you can see, all these stenosis are long-term. And plus she had a lot of collaterals developed. So we are basically managing her with some low-dose steroids. I don't think she's on any active immunosuppression because the PET CT is planned later, and I don't think we'll find much activity over there. So it's an old sequelae of Takayasu arthritis. This is another interesting gentleman who saw one of my colleagues not too long ago. We were called in because this patient was under the oncology for weight loss, lymphadenopathy, and he had a PET CT. So when the PET CT was done, this is when we were involved because the outcome was that of vasculitis. And the uptake was, like you can see, all over the major arteries, aorta was involved, and then, so he is doing well now. He is currently on immunosuppression. I think he's on as a thiopurine, plus he's receiving monthly IL-6 inhibitor, the tocilizumab. This is an unfortunate 11-year-old girl. I usually don't see pediatrics below 13, but we don't have a pediatric rheumatologist currently at the hospital. So I was called in. She was admitted with hemoptysis to the ICU. Previously well, but suddenly became unwell, so they tubed her. She had a bronchoscopy done, we had blood, she had the bloods done. And you can see in the blood test, she had a proper full-blown NK vasculitis with hemoptysis as a presentation. Now, this girl previously was well. She had some genetic disorder, but not causing any other physical abnormality. So it was a challenge because the pulmonologist wasn't very keen for us to start treatment because she felt it was a bad infection because the lavage crow bacteria, but we were of the opinion that she needs definite therapy. So at the end, the parents were double-minded, and we never got started in it. So I don't know how she's doing that because they transferred her care to a different hospital. Why I'm presenting this? Because often when we think of vasculitis, we think it's only a condition that can affect like us, adolescent or adults. So it can even happen in young patients as well. So this is a very interesting case. Why I'm presenting here, because often whenever our ophthalmologists receive any unexplained eye inflammation recurring, they usually always get a second opinion from the rheumatologist. So it's a good practice that we have developed over there. So this patient came in, he only had recurrent scleritis, nothing else. He has been well otherwise, maybe on and off fevers, weight has been stable. So all the relevant investigations were normal. So we did everything. The urine was the thing which in a way gave us a clue. He had hematuria, I think about 3 or 4 plus. So I asked the nephrologist and the urologist to see him at both at the same time. So the urologist didn't find anything, but the nephrologist requested CT angiogram, and then he had all these changes that can happen after polyarthritis nodosa. And here briefly, I can show you the changes there, but it's not the classic bleeding that you would normally see in a patient who has polyarthritis nodosa for a long time. So currently he is on like initially we started because his kidney was involved, we started him on Celset, mycophenolate with high-dose steroids. He responded, but I think he developed some issues with the Celset. So currently he's on azathioprine, which I don't like that much when the kidney is involved, but he's doing well. The important thing is eyes are better. The issue is the moment he stops the azathioprine or reduces the dose, the redness comes back. So again, it's another vasculitis without a rash. Now this boy, 14-year-old boy, he was treated in Kuwait. So he came specially from Kuwait to us, initially seen by our pulmonologist, pediatric pulmonologist. He was treated for some condition that they labeled as sarcoidosis, because I believe he had some scleritis, ankle swelling, and then he had a lot of steroids. So he gained a lot of weight. In fact, I haven't mentioned, hey, as a result of the long-term steroids, he had compression fractures, and he was treated with multiple different biological therapy, ultimately Humira, but he was not getting better. So he came to us in 2022, and the CT at that time showed that he had narrowing of the left main bronchus. So in the bronchoscopy, the pulmonologist got suspicious because the changes were not in keeping with how he has seen different sarcoidosis patients. So and then the blood test done. I'm surprised they were not done back in Kuwait. Maybe they weren't suspecting. So his PR3 came back quite strong positive. So we treated him as proper Wegener's granulomatosis, you can say. And then initially with steroids, rituximab was added, then mycophenolate, and now he's a success story. He stopped the steroids. He is just receiving 6 monthly rituximab. I think he's only on a maintenance dose of Celcept. If I remember correctly, his bones are better. He's started going back to school again. But obviously, we don't see him because I think the funding for coming from Kuwait to Dubai has stopped now. So what sort of investigations we should do? Obviously, initially, we always start with a complete hemogram or full blood count with an ESR inflammatory markers. The acute phase reactants are quite often raised, but not always. We must remember that if it's just one organ involvement like the eye or the skin, you probably will not see this raised, but generally speaking, we should do it. Urinalysis is, I think, one of the most important investigations. Why I'm saying this? Because often we do a lot for these patients. This basic test is not done, and it can give us a clue. Liver and renal function test, obviously. And antibody and complements, C3, C4, ANA, dsDNA, pointing towards lupus, Sjogren's syndrome, and then the ANCA, especially the PR3 and MPO ANCA, because a lot of time, just the C ANCA and P ANCA, if it's done, it doesn't give us the clue that we need, so we need the EIAs of these proteinases. Cryoglobulins, bacterial culture, obviously, if they're unwell, fever, so they needs to be done, along with typically for hepatitis B, C, HIV, and high-risk patients. And as I've said, a lot of time the eosinophil count is raised. IG can be raised as well. Now, radiology is very useful. It depends upon how do you see and when do you see the patient. So I've just mentioned what can be useful, but I think obviously it's an unlimited resource, and we just have to use it wisely. But typically, X-ray and CT chest are important. PET-CT, I must say, is only useful in patients who have large or medium vessel vasculitis. It will not do anything for the small vessel one. Echo, especially if you're not sure what is happening, 2D echo. Now, MON2 test or the TP gold quantiferon, obviously we also do it because sometimes patients can have the long-term vasculitis because of infection. And we also do it before we start them on any biological therapy, they need that. And ideally, they should have a skin biopsy or organ biopsy if you're lucky, but the problem is most of the time, the moment you mention the word biopsy to a patient who's otherwise well, they think we are, so it's not done now. Yeah, and then when it's done, the results cannot be that, the reporting can be a bit misleading, especially if it's partially treated. And then very important, pregnancy testing is very important when a patient of childbearing age comes in, because you have to then worry about two patients, and at the same time, you have to consider what type of treatment to give them. So the mimics, and again, it's a very big list. A lot of embolic diseases, endocarditis, atrial myxoma, cholesterol embolization, which I'm sure most of us already know you would have. Vessel stenosis, they can have sometimes spasm, especially after smoking, and that can present atherosclerosis, fibromuscular dysplasia, and drug-induced vasospasm, like intravascular lymphoma, vessel thrombosis, DIC, TTP. If I run out of time, it's not letting me talk anymore. Okay. I'll just quickly go through them. So management, In general, they have to be advised to avoid smoking, obviously. This is something which we will do in the clinic, obviously. If they are admitted under you, they probably already not smoking inside, but I've seen them smoking outside, sitting in the wheelchair. Foot and bed rest elevation. And then I'm not going to go through all of them because short of time again. So basically, they should be advised about vaccination. Flu and pneumonia vaccination are recommended, but if they need live vaccines, it should be avoided until it's absolutely necessary. And then how do you manage it? Obviously, after confirming a diagnosis, you have to find the right treatment. Usually, initially, it's always steroids, and then depending upon where the patient is, either it's cyclophosphamide, or now I use rituximab more than cyclophosphamide because it's safer in my view. And then again, okay, thank you. One last time, please. Okay. Last slide, okay, just. So this is the slide I just wanted to, so it's a brief overview of the different kinds of vasculitis, the primary treatment. As I've said, most of them will need steroids except for Schonleich-Purpura. Initially, it's mostly self-limiting. And then depending upon which organs are involved, you will choose the therapies accordingly. And then ultimately, most of them will be on long-term disease-modifying agents. Now we have specific biologics which help, especially for giant cell arthritis, so the IL-6 inhibition. And then the use of immunoglobulins when needed, especially when they have active antibodies. So as I've said, it's a big discussion on its own, so I'm not going to go through all of them, but initially, once you have ruled out all the other mimics, you start them with a proper therapy, steroids, followed by induction therapy, either with rituximab or cyclophosphamide, followed by long-term disease modification agents. Thank you.
Thank you, Dr. Haroon.